Okay, Assalamualaikum and good afternoon. Thank you to Dr. Shwen Nee who's post-call today, but will happily teach us regarding the sciatic nerve block for our regional anesthesia CME. So without further ado, Dr. Shwen Nee.
Okay, hello, good afternoon, everyone. Okay, so today, basically, I'm going to talk about sciatic nerve block and also the different approaches to it. So basically, my reference is from the NISORA and also from BJA. So firstly, for introduction, so sciatic nerve block was actually first described in 1920 by this French surgeon, Dr. Victor. So it described it as the site of needle insertion for blocking the sciatic nerve at the level of hip 3 cm along the perpendicular that bisects the line drawn between the greater trochanter and the posterior superior iliac spine. And this technique has been referred to the classic approach of Labat. Okay, so the sacral plexus is derived from the lumbosacral trunk, L4, L5 to S3, and the plexus emerges within the pelvis. And the major branch of the sacral plexus is the sciatic nerve. And other nerve includes posterior femoral, cutaneous nerve, superior gluteal nerve, inferior gluteal nerve, and also the nerve to the quadratus femoris. And some fun fact about this sciatic nerve, it is the major nerve of the lower limb, and it is a thick, flat band, and it is also the largest nerve in the body. Okay, so this is how our sciatic nerve, the cause of the sciatic nerve. It derived from the lumbosacral plexus, and after its formation, it will leave the pelvis and enters the gluteal region via the greater sciatic foramen and emerges inferiorly to the piriformis muscle and then descend in the inferior lateral direction. And once it reaches the gluteal region, it will crosses the posterior surface of the superior gemellus, obturator internus, and then once it enters the posterior thigh, it will pass through this long head of the biceps femoris. Okay, and within the posterior thigh, it will give rise to the branches of the hamstring and also the adductor magnus. And once it reaches the apex of the popliteal fossa, it will then terminates into tibial and also common fibular nerve. Okay, I just wonder, any one of you like to sit in the toilet like for very long, and then, like while you're doing your business, then suddenly when you want to stand up, then you feel like some numbness. So maybe next time you guys can take note, like which part of your foot you feel numb and stuff. Then maybe you will understand your anatomy better. Okay, so these are some of the branches, source and also motor innervation of the sacral plexus can go through it. All right, then basically for sciatic nerve, the motor function, it innervates the muscle of the posterior thigh and also the hamstring portion of the adductor magnus. And it indirectly innervates all the muscles of the leg and foot. Whereas for the sensory part, there is no direct sensory functions, but it indirectly innervates the skin of the lateral part, lateral leg, heel, and also both the dorsal and plantar surfaces of the foot. Okay, so some of the indications for this sciatic nerve block includes foot and ankle surgery, BKA, and also analgesia following knee surgery. And have to take note that additional blocks such as femoral and saphenous nerve will be required if we want to anesthetize the entire lower limb. Okay, so I will just go briefly like what are the approaches for anatomical landmark. So just now the posterior approach, as we mentioned earlier, is the classic approach lah. So we feel where is the greater trochanter. We put the patient in a lateral decubitus position, and then with the hip and also knee flex. Then after that, we feel the greater trochanter and also the PSIS. Subsequently, we draw a line. Then the needle insertion will be the midway and then 4 cm away from that. And then we have to use a nerve stimulator to confirm when we use the anatomical landmark. And then the second way is parasacral approach. So you find your PSIS and also the ischial tuberosity. Then after that, we draw a line, then 6 cm away from the PSIS, then that's the point of insertion. Then lastly will be the anterior approach. So for anterior approach, the patient will be in a supine position. Okay, then after that, we along the femoral crease, then we feel the femoral artery pulse. Then subsequently about 4 cm away from the femoral artery, then that will be the needle insertion site. Okay, but however, with the increasing availability of ultrasound, so it is better to use ultrasound to perform this sciatic nerve block, because so that we can use it at different approaches lah. Okay, so some of the transducer position that we can put is anterior, transgluteal, subgluteal, and also lateral approach. The main goal is to give the LA within the sciatic nerve sheath, and LA dose will be about 10 to 20 mils. Okay, so this is like the different at the different levels of the sciatic nerve. So that's why it's important to know the cause of the sciatic nerve. All right, and one thing special about this sciatic nerve, it is anisotropic properties. So that's why it can make it like really difficult to visualize the sciatic nerve sometimes. Anisotropic meaning like you see like a piece of wood like that in front of you. So when you put the ultrasound probe like in front of the wood, like you might see like a long rectangular shape. But if you twist it, and then the wood actually is a round shape. So that's why any minute movement with the transducer can really change how the sciatic nerve look. Okay, and then all the technique discussed later should be performed in a fully monitored environment as per the guideline. So remember, must have a good IV access, and then stop before you block, check, and also appropriate sterility, and also the ergonomics all must be adequate lah. So firstly, for the anterior approach, it is useful for patients who cannot be positioned in the lateral position, okay, due to the pain, trauma, or any X-fix devices. So the ultrasound-guided approach may reduce the risk of femoral artery puncture, but however, it is not well suited for catheter insertion because of the large needle and it's very deep. And for this approach, we need to use a curvilinear transducer. So this is how it looks like. So it's performed with the patient in a supine position. The hip will be abducted to facilitate a transducer and also needle placement. And when feasible, the hip and the knee should be somewhat flexed to facilitate the exposure. Okay, so the transducer is initially placed transversely over the medial thigh, around 8 cm distal to the inguinal crease. Okay, then after that, we slowly move down, and then until we are able to identify these adductor muscles. Then other important structures to note that is superficial, that is surrounding it, will be the superficial femoral artery. Okay. So usually the sciatic nerve will locate at the depth of 6 to 8 cm. So it's actually very deep lah. So insertion of needle in an out of plane manner using a hydrodissection is maybe a more practical way to accomplish this block. So when using this anterior approach, it's also advised to use together with the nerve stimulator because of the because it's very deep lah. So actually this is an advanced technique. So maybe if want to learn, can ask Dr. Amir because of the depth of the target and very difficult to visualize the nerve. Okay, so the anterior approach does not reliably block the PFCN nerve, posterior femoral cutaneous nerve, with a reported coverage of about 15%. Okay, next approach will be the posterior approach, which is the transgluteal and also subgluteal. So these are the distribution of the sensory and motor after sciatic nerve block at the gluteal and subgluteal level. So usually if it's usually when we do BKA, we always give like at the Popliteal region, right? So usually it cover bawah lah. So when we give this higher block, we can actually cover the hamstring muscle. But actually the skin part is not fully covered lah. So we still have to do a posterior femoral cutaneous nerve coverage. Okay. So for the distribution of anesthesia, basically anesthesia of the entire lower limb below the knee, exception of the skin over the medial leg and foot, which is also innervated by the saphenous nerve, so we have to block it separately. And also both of these approach can provide motor block of the hamstring muscle. So for the transgluteal approach, actually it's similar to the classic approach of Labat, but now with ultrasound guidance. So the sciatic nerve is approached deep to the gluteus maximus muscle, and then which is also between the ischial tuberosity and also greater trochanter. For this transgluteal approach, is also we use curvilinear probe. Okay, the position will be lateral decubitus, and then limbs are flexed at hip and knee. Okay, so this is the cross-sectional anatomy of the sciatic nerve at transgluteal level. So we can see that the sciatic nerve is actually between the greater trochanter of the femur and also ischial tuberosity. And it is just deep to the gluteus maximus. This is how we look under sonor anatomy. So usually the sciatic nerve will appear as like a triangular shape, and it is deep to the gluteus maximus muscle. Okay, so once the needle tip is positioned near to the nerve, so we have to carefully aspirate to route any intravascular injection. And we give about 1 to 2 mils of once we give 1 to 2 mils of LA injected, because it might displace the sciatic nerve away from the needle. So we might have to advance a bit more, like 1 to 2 mm towards the nerve to ensure proper LA spread. And we have to ensure there is an absence of high resistance to avoid an intravascular injection. Next will be subgluteal level. It's actually quite similar to transgluteal, but now we move down a bit, now at the gluteal crease. So now the nerve become more superficial, okay? Because it's more superficial, so now we can use a linear probe. So better choice for obese patients. So the position for this will be the same, lateral decubitus, and then flex the limb. Okay, so for this one, the sciatic nerve as seen in the subgluteal position, okay, so our aim is we will aim this hypoechoic area between the gluteus maximus and also quadratus femoris down there. And so like you see, the sciatic nerve will appear as an oval hypoechoic. So some of the pitfalls, there are several vascular structures are present within this subgluteal space, such as the inferior gluteal vessels and also committance artery veins of the sciatic nerve, and also medial circumflex femoral artery. So we should always check it with a color Doppler prior to any injection. And subgluteal approach does not reliably block the PFCN. And one study report about 68% coverage. Some of the clinical indication for this will be AKA, knee surgery below the knee. So remember, if you want to do AKA, we have to go higher up. The normal popliteal approach won't be adequate. Okay, next will be this popliteal approach that is relatively easier, okay, for all of us to learn compared to other approach. So this one is, okay, so for this posterior approach, usually the clinical indication will be like ankle surgery, hind foot surgery, midfoot, BKA, and also TKR. We can position the patient either in supine, lateral, or prone. I mean, usually for me, I prefer to do it in a lateral position. Okay, so this approach targets the sciatic nerve as it divides into a tibial and also common peroneal nerve in the region of the popliteal fossa. Usually, we put our probe at the popliteal fossa and then about 5 to 12 cm above from it. Okay, so this is the distribution of the sciatic nerve block. As you can see now, upper part is spared, so everything is below. And then take note, the medial part is not covered by this sciatic nerve. Okay, so this is the sonor anatomy of the sciatic nerve at the popliteal fossa. The two main division of sciatic nerve, which are the tibial nerve and also common peroneal nerve, which is seen immediately lateral and superficial to the popliteal vein and artery. So how we identify is, so as I said, we put at the popliteal fossa and then we slide up and down, and then you will see these two, they will somehow chantum together and then they will split it again as we move. Okay, this scanning is important lah. So the injection of the LA must occur within the sciatic nerve sheath, which is also called as a Vlocka's sheath that contains both components of the nerve. So the injection is ideally accomplished at the position where both components of the nerve are within the sheath but slightly separated by the adipose tissue, so that you just poke somewhere in between here and then the LA will float lah in between these two. Advantages, so it's a distal nature of the block, so we can preserve the hamstring motor function, and it is a very superficial block, so it is easier to learn for beginners. Okay, so one of the most common mistake for this is you only block either one of the nerve. So that's why it's important to just scan proximally until both nerves can be seen and within when they join together. Okay, so for the conclusion for this, sciatic nerve block can be used to provide anesthesia and post-op analgesia for a wide range of lower limb procedures. And when we consider which sciatic nerve approach to use, so it is important for us to understand the cause of the anatomy itself, okay, and where it innervates. Okay, so usually for me, I actually subscribe this app. Okay, and so pro from the you guys can try to subscribe. Then inside there is a lot of information that you can learn for beginners, and YouTube you can you have a look at this, or Dr. Amir's YouTube channel with a lot of slides available. Okay, thank you.
Any questions?
So, okay, good evening. So I have actually two questions. The first one will be, is there any anatomical variation for tibial nerve? For sciatic nerve. And the second one, sometimes we get a poor image. Do the block still work if the LA deposited outside the Vlocka's sheath? And that's all.
For the second question, you mean like sometimes the image is not so great, right? Yeah. That's why one of the method is to invest in a better ultrasound machine. Okay, no. And also we must improve our skill, okay? Yeah, because it's operator dependent. Okay, and also we can actually use a nerve stimulator lah. Yeah, to better confirm it with that. Especially sometimes obese patients, even like this Popliteal approach, we can't really see it very well. Sorry, the first question.
I as far as I know, I don't know of any people talking about anatomical variation regarding the sciatic nerve itself. But there are many studies that have been done regarding the PFCN. So the PFCN itself has a lot of anatomical variation. So that's why even if you do a proper sciatic nerve block, studies have shown that in general at the transgluteal, subgluteal level, the PFCN is quite nearby to the sciatic nerve. But how the PFCN innervates is a bit variable. And there are even some studies that show that the PFCN can go as low as to the innervation of the calf. So that's why sometimes you can have a good, let's say, popliteal sciatic nerve block, but patients may still have some cutaneous pain over the calf region because of innervation by the PFCN over there. But most people don't really talk about trying to specifically block the PFCN. I personally pun pernah baca only like 1 or 2 papers talking about blocking the PFCN specifically. And all those papers, they use high resolution ultrasound to actually identify the nerve at either the subgluteal or the transgluteal level. But most of it talk about the subgluteal level because that's where the nerve is still in the same fascia plane as the sciatic nerve and is more superficial before it starts to deviate away from the course of the sciatic nerve, where by the mid-thigh level the sciatic nerve is a bit deep, but the PFCN has diverged and become superficial, and it becomes a superficial nerve. I think in regards to the block quality, I think we need to remember that like Dr. Shwen Nee has mentioned, that the sciatic nerve is the biggest nerve in the human body. So the onset of block can be quite long, even with a good well-placed block. So generally they say the peak onset is generally around 40 minutes. So if your deposition is not so good, then there is a chance that your block quality may not be good as well. So I think it's very important that regarding this slide, which has mentioned regarding the Melaka sheath. So most other nerves, they are all singular nerves within a fascia plane. But the sciatic nerve is a special kind of nerve. Not only is it the biggest, but it's actually, in actuality, it's actually two nerves in one, the tibial and the common peroneal. So there are two nerves in one compartment, Melaka sheath, and therefore the immediate sheath that is covering the tibial nerve and the common peroneal is actually the epineurium. So it's not the Melaka sheath that is epineurium itself. So injecting within the plane of Melaka sheath is not considered as intraneural. So you have to get it right into the Melaka sheath, and especially if you do like a good common peroneal, like a good popliteal nerve block, you have to be able to appreciate the ability to identify the two nerves, especially when you have the LA injection, because you will be able to appreciate the distinctiveness of the two nerves within the one sheath. Okay, does that answer that question? Okay, question from online. Hi doctor, is it recommended to use nerve monitoring to identify the sciatic nerve for the anterior approach? If so, how is the placement of electrode B like? Another question, if the LA is deposited prior to the split of the sciatic nerve for popliteal sciatic nerve block, will the CPN be blocked as well?
Okay, for the first question, what I've seen before is they actually put the electrodes behind the sheath near the dorsalis pedis area there. Then after that, we will see the flapping of the foot. The foot will actually plantar flex for the anterior approach. Sorry, the second one I didn't get.
If the LA is deposited prior to the splitting of the sciatic nerve for the popliteal sciatic nerve block, will the CPN be blocked as well?
Before the split, you mean like when it is like the entire whole sciatic nerve, right? So yes, it will, but then it will take a longer period of time for it to act. Yeah, as compared to if we inject at this Melaka sheath. But anyway, after we give all this LA, we should always scan down to see how well it's distributed for the LA. Anything to tambah?
I think there have been many studies looking into the exact place where to deposit LA for the popliteal nerve block, whether after the split or or when they are splitting or right before. If I'm not mistaken, the general trend is to promote for injection during the time when the nerves are splitting. So you would see the two nerves, it's still within the one Melaka sheath, but you'll be able to identify two nerves. So that will, so you how to imagine it is that you imagine like you're wearing a trousers, wearing pants. So if you inject at the level of the zipper, imagine what you will. So you would see the LA traveling both proximal and distal, and as it travels distal, it will travel through both legs, so left and right. So the reason why they want to ensure that you have LA spread around the individual tibial and CPN is that you have greater surface area. So with greater surface area, the onset of the block is the best. So if you block it at the area where the two nerves are generally one tight bundle, then the onset of block can be slow.
When we have be it anatomical variation ke, or when we have difficulty viewing the nerve, or it's always good to confirm back rather than you just put the probe there, then you just have a transverse section of the image, then you guess which is which. It's better to just trace the nerve up and down, better, safer.
Okay, we have Dr. Ang's question. So if the patient's entire leg is very edematous, how will it affect the block?
Okay. I mean, if the patient is edematous, you mean like because of the infection itself? So due to the acidic environment, of course, our block sometimes might not be that well. I mean, it won't work that well lah. But I've also seen like edematous patient before. That somehow the block works, okay, but really we have to use the nerve with the help of the nerve stimulator. And also maybe intra-op we can also add on some like TCI, remifentanil or propofol to help with this edema.
I think basically these are two extremes. So on one extreme, you can have the very edematous patient where everything on the image is full of water, and then the other image is the elderly patient with dry tissue, where everything is bright, and you in both situations it's quite difficult to appreciate where the nerve is. I agree there is some value in using the nerve stimulator to identify the nerve, but in terms of of course we have the chemical aspect in terms of the acidic environment and onset of LA, but in terms of the physical component, if you ask me regarding the sciatic nerve block itself, it shouldn't if you get the location right, it should not affect the efficacy of the block, because if the whole idea of the especially with the popliteal sciatic is to get it within the Melaka sheath. So if you can get it within the Melaka sheath, then the injectate should remain within the fascial compartment. Even proximally to that, the nerve would still within be the intermuscular fascial compartment, and therefore the onset should be correct. The main issue is the identification of the nerve. So that's why that's why personally I find that if I have problems with imaging the nerve, I would scan the whole leg, because one of the good thing about the sciatic nerve is that posteriorly you can scan it the whole length from the popliteal crease all the way up to the transgluteal level. Of course, we have the parasacral, but I think parasacral is even a bit too advanced personally for me. So if you have doubt as to where is the nerve, then you can just put a probe starting from the popliteal region and then scan up. And if you can appreciate that there's a continuous structure, then more likely than not, then that is the sciatic nerve. But of course, if you want to scan it up and down, you might have to use a curvilinear probe from the beginning, so that you can trace it from the relatively superficial popliteal region all the way up to the transgluteal region. I hope that answers the question. Okay, if not, I just have a few comments. Can you just go back to the image on the subgluteal? Oh, I think that's the one. So for the subgluteal, just remember that the nerve, the muscle below is the adductor magnus. Adductor magnus. The one above is the gluteus maximus. So another thing that I need to highlight is that if you are doing a popliteal nerve block, it is a misnomer to say that it is a popliteal nerve block because it's quite proximal to the popliteal crease. But when you put the probe at the popliteal crease, the sciatic nerve should have divided into the two component nerves. So you must always scan proximally. And if you have doubt, put the probe slightly lateral, because the common peroneal nerve would split off and head towards the fibula neck. So as you scroll up, you might see a nerve coming from the lateral side and then joining the nerve. The issue if you miss it is not just because of lack of efficacy, but also because of safety. Because if you do a popliteal nerve block, you are going to have your needle be approached from I mean, for most Malaysians, we do an injection from the lateral side, and therefore our needle is parallel to the ultrasound beam. So if you misidentify where the nerve is, there's a risk of impaling the common peroneal nerve. There is another technique described where people do popliteal nerve blocks with an out of plane technique. There is an advantage to an out of plane popliteal sciatic because can you just show the image of the popliteal? Because if you do an out of plane technique for a popliteal nerve block, you can directly put the needle in between the two nerves, and you are definitely going to there's a good chance that you may be able to do just a single injection with an excellent spread. That's an advantage of the out of plane. And then can you just go back to the anterior approach? I've done a few, and just remember that in the right-sided diagram, that line is a bit of a lie, because that implies an in-plane technique. A lot of times, it's difficult to do an anterior approach with an in-plane technique in the sense that you need a very long needle. Just that one is just geometry. So it is best to use an out of plane technique so that your needle pass is much shorter. But of course, number one, you need to use hydrodissection to be able to identify the level of your needle. And then if you look there, you can see the SFA. So you must make sure that you do not accidentally puncture the SFA during your travel down towards the sciatic nerve. So one idea is that you can do just like you can do kind of like a saphenous nerve block, identify that plane, and then you need to increase your depth so that you can see beyond the adductor longus. Because superficial to the AMM would be the adductor longus. You may or may not see the adductor brevis. So you see the adductor longus, adductor magnus, and then deep to the adductor magnus, then will be the hamstring. And then if you scroll proximal and distal, you may be able to identify either a triangle or a flat-ish structure that will be identified as the sciatic nerve. Have you ever done blocks for AKA? Okay. I personally, for me, if I do AKA, I go probably a bit overboard, but I do either transgluteal or subgluteal plus femoral plus LFCN plus obturator for AKA lah. But the most important thing is the sciatic and femoral lah. But I think because the LFCN obturator, for me, I still see a difference when the block works and when those two blocks don't work as well. So patient we either have lateral pain or medial pain. So I still see value of it, but because it's 4 injections, it's very tedious to do, time consuming, and every block you do, there's a chance that one block doesn't work. Mm. Okay, are there any questions? So if there are no further questions, then thank you, Dr. Shwen Nee. Hopefully we'll have our next RA CME probably in July. Next month quite a busy month. Thank you.